Hello, hi, Dr. Tro.
Hey, how are you? Nice to see you again.
Good to see you. Thank you so much for joining. This is Metabolic Health Conference, India's first and largest such conference. We are doing it over 3 days, and so many people are very excited to listen to you. Welcome to the conference, and I'm stoked to have you here. So, a lot of us know you. We follow your work online, and but for the benefit of those who may not, let me take a minute and so, and just introduce you to the audience. So,
Yeah,
hey, right.
sorry,
Hi,
go
everyone.
ahead.
So Dr. Tro, he's a board certified physician based on the East Coast in the US. He's an obesity medicine specialist, and he runs Dr. Tro's medical weight loss clinic and focuses a lot on reversal of obesity and type 2 diabetes. And his main way of operating is a lot of coaching, real time biometric monitoring, educating his patients across the country. He, by the way, has a very inspiring story of his own, gaining his health back, and I'm going to be asking him about that. Uh, he has published very interesting research, including on food addiction, reversing diabetes, reducing triglycerides, using keto diet, intermittent fasting, and he passionately advocates, fundamental changes in nutrition and lifestyle, fighting food addiction, tracking key blood markers, and as some of you may know, those who have followed him online, he has a very, firebrand personality online. Dr. Rowe, we love how you, don't mince your words and you put the truth out there. And, we are very excited to have you here in the session. Thank you so much for joining again.
Yeah, I'm excited. I've been following, Shashi for a bit, and it's just a pleasure. And to see you guys come together like this with so many people. And I looked at all the speakers and I listened to some of the lectures, and it's just so inspiring what you guys are all doing. And I'm just so honored. I really am. I'm really honored to be here.
Pleasure to have you. So, why don't we start with your own story, right? I think that could be a good starting point. Could you please sort of describe, what was the before and after?
Yeah. Well, I don't know how far you want to go back, but I knew I wanted to go into medicine when, at the age of 12, I was the current weight I am now. So as a young kid, I was obese. I was, about 200 pounds, which is my current weight. And I remember going to the doctor's office, Dr. Adis. I remember him. I mean, he was a good family doctor, but I don't think he had the tools to deal with metabolic disease. He just cuts and bruises and colds and coughs. And I remember being going there on my 13th birthday, which in the United States, where we go get your annual physical on your birthday as a kid. And my just to give you an idea, my mother has struggled with obesity. My father has struggled with obesity. My brothers are both struggling with obesity. So the whole family um, really struggled. And there I am at 13 years old, waiting for about an hour and a half to see the doctor. And then he puts me on a scale and tells me, "You're fat. You're going to be like your family." And I remember that was like my formative moment. I remember, that firebrand personality you mentioned. That was the minute it started. Because the first thing I thought was, this guy just sat me in his waiting room for 2 hours. You know, they have little candies and lollipops on the counter, and then he's telling me to lose weight and basically shaming me. So I've wanted to, I wanted to become a doctor at a very young age. I was inspired to figure out, to be better than Dr. Adis. Not that he was bad; he wasn't a bad doctor, you know, but I saw that he wasn't helping my family. I mean, we were all my some of my siblings have gotten to over 400 pounds. Anyway, fast forward, I went to med school. I went to medical residency. I trained in a Yale internal medicine program where I would become chief resident, and I got up to 350 pounds. So maybe Dr. Adis wasn't wrong, you know. Turns out I had the MC4R and FTO genes, but which are genes known to be associated with obesity. And my colleagues at Yale and elsewhere would say, Troy, you should count your calories. Troy, maybe you should have more whole grains. Troy, maybe you should eat multiple small meals. Troy, and I would do my best to be healthy. And nobody, including myself at that time, I didn't want to be 350 pounds. I haven't met one patient who wanted to be 350 pounds. And so, that was my primordial ooze. I was a 350-pound doctor. I was inspired at age 12. I have a family that suffered with obesity and diabetes, and I wanted to figure it out. And my wife, about 9 years ago, really sort of inspired me to she's like, you're the chief resident, you scored on the 90th percentile on your board exam. Why can't you figure this out? And then I turned to the medical literature like I would have if this was pneumonia, and if it was pneumonia, I would have looked at the antibiotics that are available for pneumonia, how to determine the etiology, or if maybe it's not bacterial, maybe it's viral, maybe it's fungal. I would have determined the etiology of that issue and then sought the best treatments with the least adverse events. So with that lens, I turned to the medical literature, and I read probably 3,000 original articles on obesity. I read 3 textbooks, including the great Dr. Eric Westman's textbook on obesity. And what I found was that the mainstream public health message for diet, eating whole grains, eating multiple meals, having more starchy vegetables, having vegetable oils, but this is all a lie. It's not really based in good science. And all the interventional trials supported low carb. So that's where my journey started. I just wanted to be a good doctor for myself. And I found out that it wasn't exactly what we were told.
Wow.
And then I lost 150 pounds. And then the rest, the way you described it, I became a social media firebrand, mainly because I'm passionate. I've lived it. I've walked in 350-pound shoes. I know what it's like when you sit on that, plane to ask for a seatbelt extender, and the flight attendant says, get the hog strap, strap for the pig. I know what it's like not to be able to go on carnival rides, not to fit in aisles, not to go to concerts because you're not sure if you're going to be able to fit in that stadium seating. So I know what it's like, and I think that's what makes me a little bit different, and makes me a little bit more passionate than most.
Amazing, amazing. I think people who are listening will start to see, or at least start to imagine the gravity of that situation. And I'm sure you probably heard before you got into the real depths of this science. You probably heard all kinds of advice, right? There is one particular one which sort of bugs me a little bit, is that a lot of times people are told that, hey, the advice wasn't incorrect. It's just that the people are sort of, they never follow it, or they are lazy or something, right? I mean, so what do you say to that?
Okay, what I say to that is, when I was 20 years old, I ran 38 miles straight. Okay, I love to run. I helped design the gym at my medical school. I literally, when they were building it out, they had a budget. I went to the dean. I said, give me the budget. Let me help you design it. I picked out all the equipment and I worked out at the gym there. I have tried every diet, and whether it's true that I can't adhere to it, right? That, or whether the advice is wrong, to me, it doesn't matter. The results matter. And so if if a medication cannot be adhered to, if if metformin, for example, for diabetes causes severe diarrhea, a good doctor and a good medical system should be able to adapt, right? What would we do? Maybe we would try an extended release version. Maybe we would try another medication if it was needed. Maybe you don't even need it. You can go low carb, but the point is that a good medical institution should be able to look at an intervention and say, well, look, the adherence for this is very low because of the side effects. And if let's just say I was lazy, I don't know how I got through medical school and became a chief resident if I was lazy, right? I don't know how that could happen. But if it was, if I couldn't adhere to it, you have to meet the needs of the patient. We have to have other options very clear. If you can't, and the guidelines that we have in the United States by the USDA, the food pyramid, it should say, if you can't adhere to this, try low carb. Right? So if it's me that's the problem, right? Which is fine. You can have that opinion, that's your take, somebody's take, not yours, but as a good medical system, we need to provide an alternative, just like we do for any other intervention that patients can't adhere to. Right? If they can't adhere to medications due to side effects, we must adapt. We can't just keep saying, no, you have to take this. But doc, I had an allergic reaction. No, you got to keep taking it, right? You have to adhere to the medication I gave you. But doc, I'm having Stevens-Johnson syndrome. My throat is closing up, it would be crazy. So I think the reality of the guidelines is if patients can't adhere to it, right? If the whole world can adhere to it, we need to adapt. I mean, it's like the old saying, if one student fails, it's the student, right? If all the students fail, it's the teacher. So that's my thoughts on that statement.
Yeah, amazingly put. Thanks. So I know that you also attend, some of the conferences, meetings, and you are quite vocal about how the guidelines are being shaped. So since we are sort of on that topic, I just want to quickly get your opinion on that as well. That how much of a change do you see, or what's the sort of the reaction that you get from your peers? And
yeah, so I do go to I go to both metabolic conferences here in the States, but I also go to conventional medical conferences because I feel like I should know medicine conventionally, and I should be at the top of my game in their way of thinking, and I should also be at the top of my game in my way of thinking. And this is why I've continued to put out research, continue to lecture and in the metabolic space. So I think the problem with our colleagues right now is that they've come to the conclusion that in the conventional space that obesity is a genetic condition. Okay, and they look at that same thing that you said, Mandar, but they looked at poor adherence, and they say, people just can't do diets. They can't do diets, and this is a genetic condition. People can't do diets. We know the healthy diet. We've looked at the observational data. That's how they got to the guidelines. By the way, they do not. And I discussed this with panel members from the dietary guidelines. When they're looking at the data for the guidelines, they're only looking at observational data or interventional data that's not in a weight loss perspective. So every weight loss trial that's been in favor of low carb diets, a direct head-to-head or randomized control trial, it's not included in what their scope. And all the head-to-head studies showing that low carb, improves diabetes and can reverse diabetes, none of that is included in the scope of the guidelines. They're not even looking at that data, right? So they're relying mainly on interventional data for healthy people to gain weight, and they're looking at observational data. So the problem with this, and I don't know if this is too sort of advanced for the audience, but the problem with this is it's confounded. When you look at people who say eat meat, right? They're more likely to eat the bun and the cheese and the ketchup, right? And the soda that comes with that meat, right? So this sort of data is confounded, right? It's very confounded. It's not reliable, but that's what they use to make the guidelines. So the guidelines are a best guess, and they're very flawed, and they don't include interventional data. And like I said, as a doctor, we care about the person in front of us. And so when we're looking at data, we care, okay, where's the head-to-head study with one antibiotic versus the other one? What should I use, right? I want to know which one did better. Which drug should I use for cancer on my patient? Let's see what the head-to-head trial showed, one intervention versus the other intervention. And when you do that for low-carb diets, well, let's review. For hypertension, it's been studied head-to-head against DASH, and low-carb was superior. It's been studied in diabetes head-to-head against the Mediterranean diet, the healthy Mediterranean diet, and it was superior at reducing diabetes medications. It's been studied for obesity head-to-head against low-fat diets and calorie-counting diets, and it's been shown to be superior, okay, particularly at 3 months and 6 months. At 12 months, right? Let's go back to that initial question you said. Well, maybe people just can't adhere to the guidelines, and that's the problem. At 12 months, most people in a conventional setting will have difficulty adhering, right? And the way modern medicine looks at it and says, look, no diets work. At 12 months, everybody's the same, right? I think this is a key error in the thinking, right? It should be, what do we need to do to get them to adhere? In fact, I was just at this conference that you mentioned, right? And they're looking at huge data sets. They're actually doing some really interesting things with machine learning. And they found that if a family member, a doctor, and a friend all supported a diet intervention, guess what happened? They were more likely to stick to it and lose weight, right? So we should look at the best superior treatment when it comes to diet, which is low carb, without any hesitation, for hypertension, okay, for metabolic syndrome, for diabetes, for obesity. This is without question, head-to-head, low carb is superior. The next question shouldn't be, well, or the statement shouldn't be, well, nobody can adhere to the diet, so it doesn't matter. It should be, what do we have to do to make this something that's lifelong sustainable? And I think this is where our colleagues in the sort of the conventional world, going to Obesity Week, going to these, ASMBS conferences, where they need to shift their thinking, right? We need to think, how can we empower our patients? How can we help patients to sustain a diet? How can we make this something reachable for somebody in the Asian, sub-Asian context? How can we make it reachable for the guy living in Alabama? How can we make it reachable and attainable for every person? So I think the differences in the thinking come from the reliance of sort of these our colleagues in the traditional medical world on really faulty data. The Dietary Guidelines Committee is really relying on observational data, and the people listening to them, the 80% of doctors that just do what they're told and do what somebody else tells them to do, they just accept that. And then they say, well, people are just lazy and they can't do it, right? So it's a very tragic way of thinking, because people will suffer. I think what we have to do is flip the way they think, and we have to get them to say, nobody's lazy, nobody wants obesity, nobody wants diabetes. It can be reversed. Low carb is superior. And instead of saying, well, all diets fail in the end, we have to change their thinking to say, how can we empower our patients to continue doing this? How can we make it easier for them? And this is something that I've devoted the last 5-6 years of my life to figuring out.
So true, so true. So actually, I want to pick up on that thread, and then maybe have you please explain to us that, let's say a patient comes to you, right? And then how do you help them keep it sustainable, keep it going? I know you're a fan of, tracking various markers, but I would love if you could explain. the approach?
Yeah, I think so now in our clinic now, just to give people an idea, just because it's not like a typical medical clinic, I just want the listener to understand, we have 3 doctors, a physician assistant, we have 4 health coaches, 2 personal trainers. This is a big sort of team. And I'm very lucky. I have an amazing team. And so I just want to say thank you to my team if they watch this, because none of this is possible without them. But, let's go back to what a patient needs. A patient doesn't want to come to a doctor's office. They don't want to see you, right? They don't want to see, they're not going to fit in the chairs most doctors have in their waiting room. Okay. They've been shamed most of their life. They have serious medical issues. They are worried, is the table even going to be able to support their weight? Right? So they don't want to see you. Okay. They don't want to see you. And most likely, most patients, as I said, most patients realize their doctors don't know how to handle this. Right? So one, there's an avoidance to care. So when a patient actually signs up with our clinic, right, we're already delivering them information in the first minute. They get an app, they get a curriculum, they get a continuous glucose monitor shipped to their house. They don't have to even move from their home, right? They can get started within a second of wanting to establish care in my office. So this is called asynchronous education.
Mm-hmm.
And when they get the courage to make that change, right, you need to meet them where they are. They need to start now. They don't want to wait 2 months to see you. They don't want to wait 3 months to get into your office. They don't want to wait 1 hour, 2 hours like I did when I was a kid in the doctor's office. So we developed an app, and the app does a couple of things. It starts to get them involved virtually. So we have meetings like this every day of the week, okay, helping patients on various topics. Okay, if you're just starting, we have meetings for you. You meet once a week to understand the basic tenets of metabolic health and how to implement a diet safely. Okay, we have groups on fasting. We have a book club. We have lectures on advanced topics. We have in the month of November, we're going to have a free diabetes awareness lecture series. So anybody could download the app, Dr. Tro app, and attend our free 4-week lecture series. And what we're doing is we're creating that community. If you remember, I told you about that machine learning data that showed friend and family support makes it more successful. So we're creating a new family, a new friends for them. Okay, because they want to change their diet. That doesn't mean their kids are. Doesn't mean their husband or wife is, right? They want to do something else. They want to change. It doesn't mean their school programs are going to change what they're serving. It doesn't mean the commercials are going to change. What their friends are eating are going to change. So we need to create social bonds, and we need to reach them with asynchronous education in the first minute that they're ready to change. So that was step 1, create an engaging, amazing app. Step 2 was remote monitoring. You need to start to think, how can we passively engage in this person's life? The scale should connect with your office. The CGM connects with you. The ketone meter from Keto Mojo connects directly to their office. And the absence of using these things, not using the app, not using these equipment, what does it mean? Somebody takes a CGM off, stops, stepping on a scale. That means something, right? So it means that, something's going on. Maybe there's stress. Maybe it's an important time to reach out to somebody. So not only are you monitoring the data that comes in, you also want to monitor the absence of data, right? So remote monitoring, 2, asynchronous education, creating community and support, remote monitoring. So that's like three things. Then support and empowerment are so critical, right? These people, I was I'm lucky. I was a doctor. I have income. I have access to food and education. But some people don't have that. Education needs to be very simple. It needs to be fun. It needs to be it needs to be amongst their peers, right? So we create small groups where people can sort of hear and see what other people are doing on their journey. A lot of what we do in human behavior is mirroring. We see what somebody's doing that's successful and we copy it. We learn from those strategies. So we've implemented small groups to facilitate this sort of behavior change. So between, these things, the asynchronous education, remote monitoring, empowerment, using small groups, and multiple points of contact, the average patient in a 6-month time frame will interact with our office 500 times, whether it's an app, meeting, individual meeting with a doctor or health coach, trainer, whatever it is, right? Using the app, watching a module, doing a homework assignment that we give to them. And then, the advice has to be practical, right? So one of the things that we focused on is how do we help people in the systems they're in, right? How do we get people quick and easy meals at their home, at their work, at their, when they're on holiday, when they're on vacation, when they're traveling? What are you going to do? We start to empower them with easy things to do. We actually give people a McDonald's shopping list, right? Because look, the restaurants there, we are creatures of habit. The average person coming to me has about 15 to 25 foods they regularly eat and crave, right? They eat them in 5 to 15 locations with 5 to 10 people. Okay. And, that's about 60 things a doctor needs to help a patient with, right? It's not a hard list of things to do. The average person has 15 cravings that you need to address. They have struggle eating in like 15 different locations when they're at work, when they're at, home late night by themselves, when they're, visiting a friend's house for a holiday, right? And they have 5 to 10 people that they eat with. So it's not a hard task that we need to do, right? And we focus on that pragmatism. Hopefully you're unmuted and you can actually talk. So guys, if the session
Sorry.
listeners, there he's unmuted.
Sorry about that. I had a bit of cough. So
Yeah, I don't know, is that too much? But we're very thorough. We're a different practice. It's not like a medical clinic.
no, it's amazing to know. So I think you have a very thoughtful step-by-step approach. And if I may ask, the adherence rate and the overall retention rate for these guys to go hit their metabolic health goals must be amazing. I mean, do you have stats on that?
Yeah, so we have the best stats I have is so we get asked by large employers. Large employers come to us, companies say, Tro, help us with metabolic health. And they give us 500 people or 1,000 people. And they say, help us with these 1,000 people. And out of the 1,000 people that are interested in our program, we will probably take into our program because we assess readiness to change, right? So we're assessing readiness to change. We're assessing their medical needs. So we'll take in about 10%. Out of the 10% we take in, we have a very high adherence rate, 90+% adherence rate, right? And look, there's things that happen that people have to drop out. They leave their employer, they get another job somewhere, they promoted, they're fired, so once they come in the doors, the engagement rate and the adherence rate is high. But we also do a really good job of filtering out people who are not ready. We get thousands of people who just, they sign up their kid. They're like, I want my kid to lose weight. And then you pull the kid aside and say, hey, 15-year-old, would you rather be here or going and, partying and playing video games, And 99 out of 100 times they say, I don't want to be here. It's my parents. And sometimes I get the other way around. A kid signs up the parent. And, like they're concerned about their parent's health. And then you get the parent here. You say, do you want to be here or would you rather be playing bridge with your friends at the senior home? And they're like, "Oh, I'm only here because my son or daughter made me." So we do a very good job of assessing readiness to change and filtering people out of our program. Hey, maybe it's not the right for you. Maybe the guy, just handing out medications and saying, see you later, that guy would be better for you. We're expensive. We cost money to employers. We cost money to patients, and if you're not highly invested, the fit isn't good, right? Like if you want a quick fix, you can go on a medication and yeah, I don't think it's a quick fix. You'll find out very soon, just like we did with lap bands, you know, but so that has been my focus. My focus has been on making sure the person in front of me is ready to change and understanding what they need to, helping them understand what's required of them in our program. So we do a really good job of that.
So good to hear, that very detailed approach. And I think a lot more people need this sort of an approach. And it's definitely something to learn very deeply from you. Uh, I want to sort of, pick your brain on the whole food addiction thing, right? We have published on it. So for our viewers as well as myself. So one sort of angle I wanted to explore with you was, how do you look at, when people go on, say, low carb, and I know you have seen them change their food habits and, get away from their addiction. But do you sort of look at it as something is shifting in the brain, at a chemical level, maybe, or metabolic level? How do you look at it?
Yeah. So addiction, you have to look at in three. So let's get to that, right? So a patient comes to you,
Mhm.
they're smart, they know better, they want to change, and they can't, and they don't, right? And they're doing an action despite self-detriment. They have diabetes. They know that a blood sugar of 350 milligrams per deciliter is going to hurt every artery in their body, right? So how do you describe somebody who knows better and can't make a change, right? And so describing food addiction has been challenging because unlike alcohol, for example, alcohol damages several cells in the body, right? Alcohol, we don't need it to survive.
Mhm.
And yet we need food to survive. Every cell in our body needs protein, minerals, vitamins, right? And healthy fats. So we need food to survive, and yet there can be this disordered relationship. So it's important to understand that this is different. It's different than cocaine. It's different than alcohol, and it's different than it's different than other things like gambling or pornography or video games
Mhm.
that people can have addictions to. Okay, it's a little bit different, but it's similar in many ways. It is a chemical. There is a chemical, sugar. Sugar lights up the brain very similarly to other addictive substances. Fat potentiates that signal. So sugar and fat, that signal is even more strong, right? So there is a signal. Caffeine is also, has an independent signal. So caffeine and sugar are probably the most implicated. Salt can potentiate that signal as well, right? I'm sure you've seen, and if you haven't, there's pictures of these amazing goats going to death-defying heights to get salt from. So salt is a very captivating substance as well that can potentiate some that sort of addictive chemical property. So when you're looking at the data for addiction, you also look at chemical dependence and withdrawal to see if that's there. And if you've ever taken a patient and put them on a low carb diet, you'll understand that every patient goes through withdrawal, right? Every single one. And you look at radiographic imaging, functional MRI studies. These can be helpful to define addiction. And then Right. And then you look at other data, mouse model data, and sort of subjective data, right? So when it comes to food addiction, it's not an agreed upon term, but there are big groups that are trying to come together, led by Jen Unwin and some others that are trying to define exactly what this is. Okay. But a quick and dirty way that you can figure this out is, is a patient smart enough? Do they otherwise show willpower in other areas of their life? Are they eating in a way despite self-detriment, self-harm? Right? And if these three things are there, you should at least be thinking about this concept of food addiction. And screening for it is quite easy. You can take the CAGE questionnaire for alcohol and then change it for food. Do you want to cut down on your food? Right? Because the CAGE questionnaire is a mnemonic, CAGE, for cutting, agitated or annoyed, guilty, and eye opener. And if these four are answered correctly, or not correctly, as yes, for alcohol, this is a high sensitivity for an alcohol abuse disorder. If you take that and modify it for food, do you want to cut down on unhealthy food? Yes, I do. My wife doesn't. She has no appetite. She has no issues. She eats one little, piece of chocolate and she's like, I'm good. I don't need any more. So some people don't want to cut down on their food habits because they have excellent habits and it's not a problem for them. Right? Do you get agitated when somebody tells you to cut down? When I was 350 pounds and I desperately wanted to lose weight, and my wife would say, my poor wife, should say, maybe you shouldn't eat that. Are you saying, oh my God, thank you, Rosette, you're amazing. All I wanted to do was put this pizza down, right? Or do you feel gratitude? Or instead, do you feel agitation, annoyed, stubborn, leave me alone, I know what I'm doing, don't tell me what to do, I'm just going to have this one, So that's the question, do you get agitated? And what this means is you have this goal. I want to lose weight, I want to eat healthier. And then when somebody reminds you of that goal, you don't get happy. You get annoyed. There's an emotional disconnect. Your emotional, visceral response to somebody helping you remove that substance is agitation and anger. Stubborn, opposition, defiant. Right? So this is a hallmark of sort of dependence. And then the next question in that questionnaire is guilty. Do you feel guilty? Do you feel shame, right, around your food use? I've certainly felt those. And if I asked my wife, she'd say, no, I don't have any guilt or shame. I don't, I eat good. I'm fine, But for me, what does it mean? Why do I feel shame and guilt around food? It's because that emotional disconnect is, I have this strong desire to get healthier. That emotional disconnect is so pervasive and so common. I get angry, stubborn, leave me alone. Not now, later. I'll start again Monday. That now I have psychological distress. I'm feeling shame and guilt. So that emotional disconnect is so high from our mental goals. You have this central sort of frontal lobe mental goal of eating healthier, but your emotional disconnect is so great that now it's leading to psychological discomfort and psychological distress. That's shame and guilt. So cutting, agitated, guilt. And the last one for alcohol is eye opener, when you feel so compelled to drink that you drink at an earlier and earlier time, or maybe you hide and sneak bottles, right? And the same can be true for food, but it's slightly different. You don't eat in front of other people, then you lose control, home alone. You avoid social situations, you don't eat in front of others, and then you binge later on. You hide and sneak wrappers. You eat, in secret because you don't want the judgment from others.
No.
And this last step is very critical to understand what is going on. So when an alcoholic drinks at an earlier and earlier time, and when they're hiding bottles, what are they doing? Right? The psychological and emotional and disconnect and the emotional distress is so strong, but they're so captivated to the substance, they're actually changing their behavior to accommodate the substance. Right? That's what's going on. They're sneaking and hiding bottles so that they can have less psychological distress and maintain the substance. So the substance use disorder is changing the behavior and maintaining that bad habit, that bad, it's keeping the alcohol there. And with food, it's the same thing. Why, when you're eating in secret, when you're hiding and sneaking the wrappers, when you don't eat in front of others and then eat a bunch by yourself, these are hallmarks of food addiction. If you have 4 of those, that's very likely that's a substance use disorder. If you have 3 of them, probable, and if it's 2, it's just harmful use. It's just like, sort of like, you probably shouldn't be doing it and it's negatively impacting you, but you may not have a substance use disorder. Now, this isn't a science. This is just the way I do it. It's not standardized. We're coming together to form these consensuses. So the listener should just take caution about food addiction, because it's not agreed upon, and we need it to survive, right? So now you have this patient and you do the screen and you're like, oh, you're addicted to food. Well, if they go and they can't just abstain like they could for alcohol, which makes it even harder, because you have to now help them live with their addiction, right? They have this relationship to food that looks like an addiction, feels like an addiction, and they have to learn to live with it. And, here's the worst part. If you go to a family gathering and you say, I'm addicted to alcohol, what happens? Everybody hides the alcohol. Maybe they don't even drink to support you.
True.
And they don't let you drink. But the minute you tell somebody I'm dieting, what do? They're like, oh, just have a little bit. I know those Indian sweets, right? I know there's no way you're leaving that house without trying one of those Indian sweets. I know it, right? And if you say no to the sweets that somebody made, right? How is that going to be taken? Right? I know it's not going to be good. Right? What happens if you tell your mom you're not going to have dessert?
Doesn't work, yeah.
What's that? Yeah.
That doesn't
She will
work,
keep
yeah.
pushing it, I'm sure.
Right. So I wanted to sort of ask you, so I think you laid out the addictive behavior so well. I mean, I was thinking of people I know who little bit do that. So I can totally see, how it pans out as a pattern. So what I wanted to also ask you was, what do you think low carb specifically does, which, helps them? Is that mainly the satiety, and, how do you look at that?
Yeah, that's an interesting topic. So there was a Volkow at the NIH who was probably a lead scientist on addiction. She recently did a study about 2 years ago looking at ketogenic diets for alcohol cravings, and it reduced alcohol cravings. Ketogenic diets improve mental health in various ways, seizures, migraines. So I suspect there's some central action to this, right? I suspect. The other side of it is, as you said, if you have a problem with food and you're full, it's a lot easier to say no. So if you feel sated and you feel full, you had proteins and fats, it's a lot easier to address those food cravings, right? Rather than going in hungry. So I think it's a combination of these things. I think there is likely a central mechanism to craving control on a ketogenic diet. And then on the flip side, I agree with you, the satiety, whether it's, meat, fish, chicken, eggs, these are very filling foods, calorie for calorie. If you, I tell my patients, how many slices of pizza can you eat? And they all say, maybe 2 or 3 slices of pizza. I'm in New York, so it's New York pizza is to die for. 2 slices of pizza, if you're looking under the calorie prism, that's 800 calories in New York. They're big slices. And I asked them, how many eggs can you eat? Can you imagine eating 10 or 11 eggs or 12 eggs? And they're like, there's no way, doc, I can't eat that much. Right? But it's the same amount of calories. So your point about satiety, I think, is really critical, because calorie for calorie, it is a very satiating way of eating. Particularly if you stick to whole foods and real foods. Now, I think there's likely other mechanisms. And Volkow's work, what we know about the centrally acting effects of a ketogenic diet, I think, we don't have the data. I'm just theorizing here, but it's most likely also centrally mediated. I mean, how can it reduce alcohol cravings? So there must be some activity on the brain.
Amazing. So I want to sort of now go from micro to macro a little bit. Currently, how do you look at the overall scene of metabolic distress in the US? And maybe joining with that, do you see Indian patients in your practice, and what differences do you spot?
Oh yeah, I have a big sub-Asian and Asian population, a lot of Indian patients. I think some of the challenging parts, I have some that eat meat and some that don't.
Mhm.
And I tell them, look, whatever you want to do, I support you. I've had a lot of people, they eat meat on their own. Like I don't push it, and they all of a sudden they're embracing meat, particularly fish and chicken. So I think one of the barriers in that population is, there's a lot of meat phobia. Forget about the religion, like just outside of the religion, even, there's meat phobia. It's funny. I have a physician colleague, and he hadn't eaten meat. And I asked him what his grandparents ate, and he said fish and coconut. Like that's just part of the India that his ancestors were from.
Right.
And eventually, his triglycerides were high. This physician colleague started to eat fish and coconut, and his triglycerides improved.
Mhm.
But I think you have to we have to figure out ways for people who decide they don't want meat. A lot of Greek yogurts, a lot of eggs, foods around, these stuff. Can we use cheese in creative ways to make different foods? How can we replace we have to replace bread, the flatbread. What do you guys call the flatbread,
Roti,
right?
the roti, yeah.
Yeah. So we've come up with ways with almond flour to replace that flatbread,
Mhm.
so that patients can, feel culturally, that something is not taken from them, and then from a metabolic perspective, you know, uh, I, I'm going to be honest, white people have it made. They can get a lot fatter.
Right.
They can get a lot fatter. I was 350 pounds until I showed high triglycerides.
Mhm.
So my sub-Asian patients, they can't even put on 10 pounds, 20 pounds, right? They will see visceral fat much earlier than a white person, right? And docs need to know this, that it is much more likely for an Asian sub-Asian person to experience metabolic disease at a lower weight, right? And they're much more likely to get metabolic syndrome and diabetes at a lower weight. So I think the challenge for the Asian sub-Asian population is that they need to be much thinner
Mhm.
than to get that sort of metabolic health. And this is likely genetic. It would make you a very formidable, opponent, right? To be able to have lots of blood fat and blood sugar, right? You can go fast and run 25 miles, fight a warring tribe, and then come back and be totally fine. But for in a world where food is everywhere,
Mhm.
um, I think this is a challenge. I actually would say it is probably more difficult. It is more difficult for my patients who are Indian and Asian, sub-Asian. So I think that these are the things that I wish doctors would know, that you can't use the same metrics. Measure visceral fat.
Mhm. Mhm.
Measure visceral fat. And if you measure visceral fat and you look at the triglycerides and the blood sugar, right, their weight may need to be much less than white, Black, Hispanic people. And then overall, I mean, this is a disaster. This is a worldwide disaster. We're facing 90% of people with at least one component of metabolic syndrome.
Mhm.
I mean, it's sad. It's so much suffering. There's 100,000 people losing limbs to diabetes. I mean, our kids, we have a pediatric obesity and diabetes epidemic in children. In children, they're talking about giving drugs and surgery to 6-year-olds, okay, for these issues. And I think that's a huge problem. And this, I think, is the easiest way to show the error in our colleagues' thinkings in the mainstream approach. That they're thinking it's okay to cut the stomach and inject a 6-year-old with medications that are poorly tested, particularly in that age group. I understand the problems of obesity are pervasive and metabolic disease are pervasive, but there is something wrong with us as medical providers that we've been unable to do better. And the ways that we have done better, cutting people's stomachs out or putting a lap band or giving them drugs, these are short-term solutions, and they have long-term complications. So if we can develop ways to empower patients not to need these things, we should. And we should not give up and just say, patients can't adhere. If patients can't adhere, if all the students can't adhere, it's the teacher, right? So I really wish that we can get our colleagues to look at metabolic health differently and empowerment differently.
Yeah, like the way you put it across, no holds barred. I wanted to sort of ask one quick question because you have published on this topic as well, and you mentioned triglycerides just now. So sometimes people struggle with this idea that, hey, you're sort of telling me to eat low carb, so sort of my fats are higher now in the diet. How is it going to reduce my triglyceride, or how is it going to, help me lose fat? So how do you sort of explain this science to them?
Yeah, so the triglycerides is pretty interesting, right? So it's true, when you eat fat, your triglycerides go up. But what happens is as you eat, as you're void of carbohydrates, right, your fat oxidation goes higher and higher.
Mm-hmm.
And so what happens is your body becomes more efficient over about the period of 10 days at using fat for fuel. And you can quickly see that triglyceride level come down quickly because many people have never had to really ramp up their fat oxidation, their fat burning capacity.
Mm.
I mean, who's fasted for 3 or 4 or 5 days? Who's eaten low carb consistently for 10 days? Very low carb. I mean, like 20 grams or under, right? So most people's sort of machinery, it's got a bunch of dust on it. Their mitochondria has only gone one way. So you can rapidly see that. And what we've done here in our office, if we have doubters, I say, we have a lipid machine here. You can do your lipid every day if you want. I don't care. You can see it come down.
Mm-hmm.
Now, if it's dangerously high, so I don't know if you guys use the same metrics as us, but if if a triglyceride level is in the thousands,
Mm-hmm.
right, this may require, so if the blood fat is in the thousands and you're having excursions up another 1,000 due to like an LPL deficiency or some sort of genetic issue, right, which is possible, but although it's rare, you may want to do a low carb, low fat approach for the first 2 weeks until the fat oxidation increases. And then you can add fat and see what happens to their triglycerides. But even that approach is not necessary 90%. Like if it's under 1,000, I wouldn't care. I not that I wouldn't care. I would be much less, apprehensive. So yeah, what happens? It's true, if you eat fat, you can get a triglyceride excursion and triglyceride level goes up. But the ability of your body to use that rapidly outpaces any of these excursions. And we have fasting triglycerides of people that are undetectable, under 50, under 40. I mean, meaning like their body is very efficiently using fat for fuel. And so eating fat, causing fat, I mean, I think that's not hard. Most of the time, the patient's coming to me, by the time they've used our app or seen a video or seen a lecture or watched Ken Berry on YouTube or heard the Low-Carb MD podcast or whatever it is, they already have done away with that. But if there's true naysayers, that's what the app is for. Like, here's the data. And in the app, we share the primary studies, so they don't have to trust us. And ultimately, I tell them, you shouldn't trust me. We're tracking everything, the lab work, the blood sugar, the weight. You're going to be the first one to tell me, look, it's not changing. Right. So I hold myself accountable. I am seeing, is my advice actually having an impact? And when it doesn't, sometimes we do reduce fat. Sometimes people can, do a lot of heavy whipping cream, cheese, and nuts. And, sometimes we have to course adjust, right? And we may adjust some of these things, or they're snacking, or they're stress eating, or they're anxious eating, or they're sleep deprived and getting hungry. So we can course adjust. But ultimately, nobody should trust me. They should all verify me. And that's why we check labs very frequently and remotely monitor as much as we can. Nobody should trust me. I'm going to show you, because the difference between us and them should be, we're results driven. The guidelines have failed. The results are terrible. They think that their scientific method is correct. Their error is the results are terrible. Everybody's suffering. Everybody has disease. So we should go the other way around. We should be results driven. And this will help prevent the same mistakes that they made.
Absolutely loved it. Yeah, I think the accountability and proof is in the pudding, right? So you show them that it works. That's the best way. So we are almost near closing. So let me thank you once again. It was lovely chatting with you. And I'm sure folks have learned a lot of new angles of looking at low carb and their relationship with food. I also want to request Shashi and Anup to join just for a minute.
Guys, I'm huge fans of you online. I just want you to know, both of you, it's nice to finally meet. I know we're probably going to wrap it up in the next couple of minutes, but this is amazing what you guys have done. And I know it's not been easy for both of you guys.
Dr. Tro, personally, I want to thank you in this platform, because the moment I messaged, you readily agreed to come to this platform to speak today. And I think your story is very inspiring. We have seen, many of us know the kind of journey you had. And I think many of us in India also know, but most of them who are going to see this video may not be knowing about a journey. And I think that is very, very inspiring. The kind of weight loss journey and the kind of addiction subject is something which you come out very, very clearly. And I think we will need a lot of more sessions with you in coming times also. I want to thank you from the bottom of my heart.
Can I just say, I want to thank you guys because I know, particularly in India, this is not easy to do. And I know you guys have faced a lot of, unfortunately, unnecessary criticism, and I just am so honored to be here. I was telling Dr. Gadre here that I'm just honored. And it's honestly that population that I think needs this message the most. Certainly in I think we have to change the medical landscape there, and it's going to be challenging. I know you've been working on it for years.
Yeah, concluding message. Concluding message, doctor. I'm Anup here, and besides what Shashi has said, personally, I love you for one thing, that is being brutal. Because I also belong to same segment on Twitter. I'm very brutal, and I remember, one doctor from India, you had taken him on very brutally few years back. I won't name him, but thanks for that.
I'll name him. He misdiagnosed rhabdomyolysis. He misdiagnosed rhabdomyolysis. It was classic case of rhabdo, and he says this was due to protein or something. I don't know what he said. It was something so silly. And this guy has hundreds of thousands of followers. I forget what his name was, but I was like, I really think you missed that. Oh, he said it was shock liver what the liver in. So when you have rhabdo, which is a muscle breakdown, just for the listener, which is a breakdown of muscle tissue, you can have elevated liver enzymes. And he's a GI doctor, I think. And he said this was due to shock liver. And I'm like, you're completely wrong. He has myoglobin in the urine, hallmark of rhabdo, and he has elevated liver enzymes, which is beyond common to see in rhabdo. And he said it was shock liver, and I humbly pointed it out to him. I'm like, you got it all wrong, guy. And it did not go well. So I do not envy what you guys have to put up with if that's how most doctors are. I think that's what you're talking about, but
Thank you.
Yeah.
Thank you for coming.
Yeah, no problem. Thank you.
Namaste from India.
Namaste
Thank
from
you.
India.